I trained in UK in all aspects of orthopedics and trauma. I have special interest in computer-assisted robotic 3D augmented knee hip surgery. I did the General Medical Council of the UK recognized fellowship at remote teaching hospitals for the same. I also have specialist interest in hip and knee sports and revision surgery, for which I did a fellowship in A1 Orthopedic Center in Bristol, which is very famous for the A1 knee.
These are the facilitator sessions, and from the experts of expert domain, this is a contribution to the society as a whole and to the academy also. So there are special experts we have made for each subject, and they share their knowledge and experience in these sessions. Today we have with us Dr. Srikanth KN, and he is a very well-renowned ortho surgeon and practices in the Bangalore. And he has got training from UK, and he's very passionate about technology and artificial intelligence and robotics. We want to talk about robotics in orthopedic surgery.
Good evening, dear doctors and friends. Welcome you all to this presentation on robotics in orthoplasty. Is it better in 2024? So basically, I'll be taking how deep this sort of new technology goes. It is orthopedic related topic, but I'm pretty sure it is very relevant to all the other fields as well, because technology is here to stay, and we have to, as we have discussed in the AA module, we have to adapt to new technologies to survive in this market. And that's the way things are going. So many new people have, joined whom I don't know. So a bit of brief introduction about myself. I'm Dr. Srikanth KN. I'm consultant knee and hip surgeon. These are my qualifications. So very proud to have worked in Wrightington Hospital, the birthplace of joint replacement surgery in the world. I was formerly a consultant in trauma and joint replacement surgery in the UK. Presently, I'm proprietor and MD of Sarthi Superspecialty Orthopedic Center in Davipuram, Baswangudi, Bangalore. I'm also consultant in a cohort of corporate hospitals like Apollo Specialist and Prakriya Group of Hospitals in Bangalore. At the outset, I would like to take this opportunity to thank Dr. Pranav sir and Mr. Amit sir for this opportunity to present. And I welcome all the delegates for this, what will be a slightly futuristic talk. So about myself, I trained in UK in all aspects of orthopedics and trauma. I have special interest in computer-assisted robotic 3D augmented knee hip surgery. I did the General Medical Council of the UK recognized fellowship at remote teaching hospitals for the same. I also have specialist interest in hip and knee sports and revision surgery, for which I did a fellowship in A1 Orthopedic Center in Bristol, which is very famous for the A1 knee, which they sort of invented there. Also, I spent time doing a septic revision, that is infected revision fellowship in Hamburg under Prof. Gurka, who is a world authority on this, where we replace the infected joint, knee or hip at the same setting. So, and my center does offer quarterly referral service in India for this very challenging kind of patients. I did my UG and PG from the prestigious Bangalore Medical College Research Center, and I was a National Merit Scholar throughout. I sort of bring experience of more than 16,000 joint replacement surgeries over 14 years in the UK. Very fortunate to have worked in 4 out of 5 specialist orthopedic units in the UK, which are called Centers of Excellence, because the infection rate there is the lowest in the world. So I was very fortunate to have trained in all the 4 out of 5 of these centers. I'm also director of the International Meet the Masters course. We bring it each November, and in the 4th Meet the Masters course, we push the boundary of our understanding in joint replacement surgery, what we call as orthoplasty. We dealt with robotics in hip and knee orthoplasty in November 2021, and this 4-hour program I've sort of concised it into around 20 to 30 minutes talk today. And in the next year, we brought augmented reality in orthopedics. What is the role of that? And in the last year, 6th, Meet the Masters course, we talked about artificial intelligence in orthopedics. The great Newton, has made this iconic statement after the discovery of gravity. So he said, if I have seen further than others, it's by standing upon the shoulders of the giants. So I think no talk of mine starts without being very grateful and showing gratitude to our teachers. And we have some of the best mentors here, Dr. Pranav sir and Mr. Amit sir, and they've been mentoring all the group in a fantastic fashion. So, I always start most of my presentation with my gratefulness to my trainers. This is the big one. This was in Meet the Masters course 2020. This is Professor Alistair Hart, who is on the right-hand side. He's a full chair professor in the University of College London, UCL London. UCL is the largest teaching hospital in the whole of Europe, and Professor Hart is very well known in the whole of Europe, UK, and US as well. And in fact, the BBC has nicknamed him as the hospital hip detective. And this was during my visit to the London Implant Retrieval Center in Stanmore Hospitals just before the pandemic. And on my left-hand side is Professor Professor John Skinner, who is the immediate past president of British Orthopedic Association. So these are very big names in orthopedics in the world of orthopedics. They're quite big names. So I was very happy and grateful that Professor Hart was able to talk to the Indian orthopedic surgeons via our meeting on the 3D printing in orthopedics. So very futuristic. And we had an exciting debate about the future of orthopedics between my mentor and him in that particular meeting in 2020. Experience relevant to this topic, I trained in UK in all aspects of orthopedics and trauma. Special interest in computer-assisted robotic knee hip surgery, patient-specific implants, for which I did a GMC recognized fellowship at the Plymouth Teaching Hospitals. This was more than a decade ago in 2011. This was a presentation of fellowship by Dr. Jonathan Keenan, the director of orthoplasty at Plymouth Teaching Hospital. So my love and passion for the computer-assisted surgery and robotics started here with Dr. John Keenan. This is my second fellowship, a revision fellowship, hip and knee at Avon Orthopedic Centre, Bristol, UK. This is Dr. Edward Smith. He's a UK head of European Hip Society, and he's the director of the world famous Bristol Hip Orthoplasty course. So he's my hip mentor, and also worked with Mr. Anthony Ward, who's the director of pelvic acetabular surgery for the southwest of UK. This is Edward doing the first minimally invasive spare approach in India, in All India Institute of Medical Science, New Delhi on the left-hand side. And in the right-hand side, we have the inaugural Meet the Masters course, where he's being felicitated by my professor, Dr. Jai Krishna Reddy, and Professor Purushottam. Both of them were quite high in the KOA presidents, and many from Karnataka would know them quite well. This is, I worked with past president of British Knee Society, Dr. Richard Parkinson. He is my knee mentor, and he was the president of BASC for 2 years. And he was voted the top 10 best knee replacement surgeons and teachers or trainers in the UK. And he inspired me to take up knee surgery way back, in 2002. That is more than 2 decades ago. This is my dream or manifestation come true. This was 1st of December 2023. That's just 2 months ago. So I was in the UK in Bristol as an invited faculty in the Bristol Orthoplasty meet, and I met my hero, Professor Manoj Ramachandran. Those who have done FRCS or done any advanced degrees in the developed world know that there's a book called Basic Sciences in Orthopedics, which is a must. You need to read that like back of your hand to pass the exit exams in the West. And Professor Manoj Ramachandran has written that. So he's my hero in orthopedics. It was indeed a privilege, a dream come true for me to meet him recently. And also, we are collaborating with him as well, which is the second icing on the cake. And to just tell you briefly, he's the master of AA. If you need to go to AA, anybody in orthopedics, he's the guy. So he's an amazing person. Coming to today's topic, knee and hip arthritis. Around 20 million people in India suffer from knee and hip arthritis. Almost 1 in 5 Indians. Around 1 in 4 of them might need some kind of surgical intervention in their lifetime. COVID proved that there's a big doctor shortage in India. Because of this big skills shortage, almost everyone is like trained or untrained is forced at these hip and knee replacement surgeries. If you look at there's a basic tenet in computer-assisted surgery or robotics, GIGO, garbage in is garbage out. And we use that in Dr. Pune Academy quite a lot as well. And there's a basic rule in orthoplasty, that's joint replacement surgery. If you fail to prepare, you prepare to fail during surgery. And these things are very important lessons, and I will see why it is important in the next few slides. Coming to knee, we call a knee as a complex 3-dimensional hinge, because like a door hinge, a door only opens like that. But just imagine your door in the house, which can open like this, but can also rotate, at the same time. You can just imagine how complex that mechanism would be. Knee does that, human knee does that. That's why it's called as a complex 3-dimensional hinge. So there are a number of doctors here, many of them are not orthopedic, so I'll keep some of the concepts very basic as well. When anybody comes with a knee pain, we do ask, what is causing the knee pain, like the age of the patient, whether there is any injury involved leading to pain, and where is the site of the pain, the location. and did the symptoms start suddenly or over a period of time? Once these questions are answered, we start investigating and putting the symptoms with signs together, and the investigations often lead to diagnosis. MRI or latest investigation like PET scan is not the first investigation of choice. This I say because when I moved to India, I had a patient who had seen multiple surgeons all over India, like 15 surgeons, including neurosurgeons and all. And he came to me with a lot of scans, PET scan of the back, MRI, everything. And all that he needed was for somebody to put him on a couch and examine him. Okay. When we examined him, his hip rotations were restricted. We got a simple X-ray, which was 200 or 300 rupees at that time, that clearly showed the avascular necrosis of the hip. That means the hip blood supply had been cut off and the hip head had undergone necrosis. That means it had died. What is called as a AVN in the orthopedics. Okay, so it just needed a simple examination of the patient and an X-ray, not a PET scan or some kind of an advanced scan. So often I think we should start from the basics, and once basics are done, we should go to more complex investigations. So basically, my take-home messages as far as arthritis is concerned is pain while walking down the steps is very commonly associated with kneecap or patellar problems such as chondromalacia, patella, or osteoarthritis of the patella. Morning pain, that is morning pain with stiffness that gets gently better with gentle activity, is typical of early arthritis. Sharp pain with clicking, locking of the knee is due to meniscal pathology or a patellofemoral or kneecap problem, or sometimes loose bodies in the knee. A sudden pop in the knee associated with swelling and a knee giving way, typically in a young person who's involved in sports, is due to a cruciate ligament injury like ACL, PCL, would have heard in all the IPL players, footballers, and things like that. Arthritis of the knee can start, even rheumatoid arthritis or inflammatory arthritis can also commence in the form of isolated knee arthritis, and then it can spread to other joints. These are the basic X-rays we do, and these are the basic blood tests we do. We usually tend to get a long, weight-bearing X-rays to see what's happening with the overall limb alignment, whether it is in varus, which is inside deformity, or valgus of the knee, which is the outside kind of deformity. So that is like a bow knee or a knock knee. So then we do some measurements like valgus cut angle and mechanical axis of tibia. What are the treatment options and what are the principles? So always, any patients coming with pain, any department, whether orthopedics or non-orthopedics, we always use the WHO ladder. We start with simple painkillers like paracetamol, and then work our way up to non-steroidals and up to the morphine and diamorphine, that kind of a thing. So once we employed the painkillers and followed the WHO ladder for isolated knee arthritis, if there is no infection, one can inject a local anesthetic into the joint, and PRP has become very common in the last 2 decades, really. And we've been injecting, Synvisc, which is an artificial synovial fluid. I did an RCT in Europe and published the efficacy in the Journal of Knee Surgery in Europe about the use of Synvisc following arthroscopy. And there's something new thing which we launched here in Karnataka called as a joint widow, which is a SVF, which is acting like a game changer in arthritis, actually, particularly in early arthritis and AVN. And that's been a fantastic development in the last 8 months to 10 months. Treatment of OA of the knee is like OA of the hip. For role of physiotherapy is very important in getting balance, improving strength of the muscle, etc. And there are newer approaches, approved braces like off-lateral knee brace helps. Insoles can be very useful in knee arthritis. What are the types of knee replacement surgery? Knee replacement would have heard a lot, but you don't have to always undergo knee replacement. There are many simple surgeries which can be done before we have to end up in a knee replacement surgery. So one can do what is called a diagnostic arthroscopy, where we put a scope inside the knee, see what is going on. And if there is a problem with a meniscus, a meniscal tear, that can be trimmed or it can be repaired. If there is a loss of cartilage, then we do what is called an arthroscopic microfracture, where we take drills and then create number of holes within the bald bone. So it sort of regenerates the fibrocartilage. Again, in the same areas, we can also do what is called arthroscopic horse grafting, where we take pecks of bone from the non-weight-bearing areas and put it like pecks, like cigarette pecks, in the weight-bearing areas where the cartilage is completely lost. Or one can take some samples of the cartilage, put it in a petri dish, grow it in a lab for 6 to 8 weeks, and bring it back and transplant it in what is called as artificial chondrocyte implantations called AC and AC. And if there is a ligament damage, like the anterior cruciate ligament is scarred, PCL is scarred, then we can replace them. What is called ACL surgery, PCL surgery, or posterior lateral complex reconstruction. Coming to indication for knee replacement surgery, majority is osteoarthritis, around 96%, inflammatory arthropathy in a small proportion, and post-traumatic arthritis in even a small proportion, less than 1%. Average age is around 67, slightly female preponderance compared to male. So what are the types of knee replacement surgery? So always we don't have to replace the entire knee. So the knee has got basically 3 compartments, and we can look at which compartment is damaged, whether it's the medial, which is the inside compartment of the knee, or the lateral, which is the outside compartment of the knee, or the kneecap, patellofemoral joint, and we can isolatedly replace these individual compartments. So this is called a uni operation, and this uni is becoming very popular in India in the last 5 to 7 years now. And also osteotomy, where we sort of cut the bone and realign the bone. That's also, coming back in a very strong fashion. It had gone out of usage, although it was a go-to choice in 40, 50 years ago. Now it is making a comeback. And in fact, we broadcast the Basingstoke osteotomy course to the whole of India in December a few years ago. It's again available through the link on the last slide that I'm going to show. And last, if all the compartments are involved, one does a total knee replacement. So what is new in total knee replacement? Computer-assisted surgery, that is called navigation, robotic surgery, 3D augmented surgery, use of augmented reality and mixed reality. These are all new in total knee replacement surgery. So basically, what do? They address the alignment, that is how the knee should be aligned, versus balance, like how stable the knee should be. So that conundrum is there even in 2024. That is addressed by these advanced technologies. It provides predictable accuracy, makes surgery safe, recordable, and prepares better surgeons of tomorrow. Because we really need, if I want my knee to be operated, I really want a young surgeon who is really good, who is top of the game to do that. I'm sure all of you will agree that that's what you all want, really. Okay, so the advanced technology leads to transparency, future learning, and accountability, which is very much important. So they also act like a patient-specific implant. Like, in the last 15 years, what we now know is that the nature has created each knee in a very individual fashion. No 2 knees are the same. So you have to give a specific solution, like customized solution to each patient or to each knee. So we now know that all knees are not the same. So common myths, when I moved to India, I had to interact with a lot of senior surgeons, and some of them used to tell me, Shrikant, the eyeballing is better, than computer navigation. Robotics had not come at that time, and I had very difficult time to convince them that why it is important and things like that. And very strangely, post-COVID, the robots came, which were based on the same principles as computer navigation. And suddenly, these very senior surgeons were the first to, put in several crores of rupees and buy the robot, which was based on the same principle. So you understand where they were coming from, So that was a very interesting experience I had. And then there's a concept that one size fits all, like, give size 8 shoes to everybody. But it's not true. Every knee is unique, and you need to give specific kind of treatment to specific needs. For example, somebody is size 7 shoe, you size 7 shoe. You can't put a size 9 shoe. So then now looking at an X-ray and doing a knee replacement in 2024 means we are only giving a 2-dimensional solution to what is a 3-dimensional problem. So knee is a 3-dimensional problem, which needs a 3-dimensional solution. And then sometimes people say you can always plan surgery on the table. So I completely disagree with that. An operation table is a place where you execute the plan that you have made already. Operation table is not a place where you plan surgery. So, so that's the fundamental difference, really. And then there is a concept that, anybody can do knee replacement in India. A lot of the CEOs in the hospital tell me this. It's like a EBITDA kind of driven concept. So we understand why it is. But I'll show you why their concept is wrong, really. Because this is Dr. John Insall. He's the father of knee replacement surgery at the Hospital for Specialist Surgery in the USA. And he told that knee replacement is a soft tissue operation, not a bony operation. Although we cut bones as orthopedic surgeons, Prof. Insall said that knee replacement is a soft tissue operation, not a bony procedure. So it has really taken like 50 years now, 5 decades for us to understand what he really meant, because great masters and teachers are always ahead of their time. And we now, with the advent of robotics, start understanding what he was talking about. Respecting the soft tissue envelope, aiming for a functional alignment and balance, triumphs the alignment philosophy now in 2024. In 2024, there is no role for release of the medial collateral ligament, particularly the superficial one, because it's not involved in the disease process. In 2024, we are debating whether it should be mechanically aligned straight like this 1990 cut, or there should be a kinematic alignment, or they should be adjusted mechanical or inverse kinematic or functional. I'll go into some of this in detail later. But it's just changed, how we were thought about mechanical alignment 1990 cut, put the implant, and now there are proponents for each of these different alignment philosophies. So why TKR is a soft tissue operation? I'll just basically not bore you much. What it means, this slide means is that every ligament in the knee has got multiple functions. For example, I'll take a simple thing like primary restraint to anterior translation. Like, in dashboard injuries and all, we find that, if the tibia has to go forward on the femur like that, that is prevented because of an intact anterior cruciate ligament. But that is also prevented because of the iliotibial band. It is also prevented by medial lateral capsule by 20%. Also, medial and lateral collateral ligament are offering 10% resistance to that kind of anterior translation. That means every ligament in the knee is doing multiple functions. And in 2024, if you're really honest, we really don't understand the function of all the ligaments in the knee. Okay, that is where we are. 6 degrees of freedom. Knee, as I mentioned, is a complex three-dimensional hinge. It can not only open like a doors, like our doors, but also rotate. Okay, that's why it's called a complex three-dimensional hinge. And we say that knee has got 6 degrees of freedom. That is, when it is bent, it can move from side to side. When you are standing, it can rotate like that. When you are standing, it can compress and distract because it's a sponge. And when you are bent like that, it can, sort of wobble like this. Or it is like a ball, it can, like a ball, it can sort of rotate along an axis called as a transepicondylar axis. Or it is like a ball, you put it on a slide, and then the ball rolls down. And the knee also sort of rolls down like a ball. So these are the 6 degrees of movement. To do a knee replacement surgery, we need a basic 3 cuts. 1 cut on the femur, 1 cut on the tibia, 1 cut on the patella. If we combine these 3 cuts with 6 degrees of freedom, there are 215 ways in which a senior orthopedic surgeon can get a knee replacement wrong. Okay, this I'm not talking about juniors or fresh pass, but a senior guy can get a knee replacement wrong in 215 ways in a single surgery, if he is not giving attention to the details. So I'll just answer the question, real answer, whether anybody can do a knee replacement, So if it's EBITDA driven, yes, probably the answer is yes. But if it's a patient driven, it's a clear no. So if you have patient's interest in your heart. Primum non nocere. That is, first do no harm. It's the first basic principle of medical ethics. So if in doubt, it's ask, there is no shame in asking at all. So a proper training and experience is a must doing these surgery. That's why these modern concepts like navigation, patient-specific implants, 3D augmented reality, and robotics are coming. See, limitations of human eye. The human eye is not, it's got a number of limitations. Eyeballing can't differentiate more than 10 degrees change in various valgus angulation of the knee. But we know in knee replacement surgery that more than 6 degrees change in various valgus alignment of the limb causes catastrophic failure of the knee replacement. There are a number of references for that. So we don't want a bad day at office to affect the outcome of patient surgery. We are all human beings. We have good and bad days. We might have fought with somebody in the road while driving, so many things. We don't want that to affect. We want to minimize surgeon error. When so many factors are at play, some known to all of us, many, like the role of ligament, still unknown to us in 2024. And 1 millimeter accuracy is humanly impossible without using a robotic burr. Then alignment, what alignment and how balance, which is important. That conundrum is still not fully resolved in 2024. So there is a number of varieties of these advanced technologies, from patient-specific implants to navigation to robotics like Navio, Mako, Cubis, Omni, etc., and 3D augmented knees like the Ironman robotics or humanoid robotics. I've used most of these. Most of these technologies are very interesting technologies. And again, why all these changes are happening. They say change alone is permanent in life. And we thought, as I mentioned, knee is a hinge, like it opens like a door. Then they went into J-shaped kinematics, which many of the orthopedic surgeons would know. Then they thought it will move, along a transepicondylar axis in the femur. But now the latest thinking is that it moves along a transcylindrical axis. So what is this? This picture tells us what is a transcylindrical axis. The green line there that you see on the bottom is the transcylindrical axis. The yellow line is the transepicondylar axis. Most of the knee surgeons put the femoral component parallel to the yellow line, but ideally they should put it parallel to the green line. And the green line is specific to each patient. It is patient specific. So that's why these modern concepts are coming. So, this is the transcylindrical axis. So what has changed, old versus new? In the West, the literature clearly shows that 3% of knee replacement need revision within 2 years after surgery. You do surgery, in 2 years, they come for revision. These are called early failures. Why? That paper, if you go deep into the paper, it says 20% of these failures are occurring because of instability. Instability means either the component has not been aligned properly, or the balance of the soft tissues around the implant has not been achieved. Okay, these are both due to surgical errors. Okay, whenever any failure occurs, you have to divide that into SIP factors. Prof. Alistair Hart taught this, after the ASR debacle. SIP factors. SIP factors stand for assist surgeon factor. So I is the implant factor, P is the patient factor. So all the factors combined together leads to a failure. So here you need to look at why this instability is occurring, because it is poor alignment and poor balance. Both are surgeon errors. And, not sort of doing a reduction osteotomy or trying to chase a neutral alignment, forces one to release the non-diseased superficial MCL can also lead to these kinds of issues. Overall, the literature shows that around 20% of patients after knee replacement are not completely happy; they're dissatisfied. So we are trying to reach a stage where we decrease this 20% to close to 5% or 0%. What is called as a forgotten knee or a holy grail of knee replacement surgery. Alignment. Again, alignment concepts have changed. Earlier, it was mechanical, keep it straight, 90 degrees cut, 90 degrees cut. And these concepts have changed. Probably Pragnano says that mechanical alignment in 2024 is dead. And now we have got various personalized alignments like kinematic, inverse kinematic, restricted kinematic, and functional. So I will not go much into detail because they are complex, but I will discuss about the latest alignment, what is called as functional alignment. This is Vinod talking about inverse kinematic alignment in 2020. Very interesting, and restricted kinematic alignment. And this functional alignment, our center was the first in India to introduce this concept of functional alignment. This was happened 2 years ago or 3 years ago when Prof. Acharya talked about it. And because the meetings are broadcast quite a lot through our media channels, a lot of surgeons picked it up. Most of the robotic surgeons now in India follow the functional alignment. So here, basically we are looking at the 3D anatomy and trying to balance everything and all the X, Y, and Z axis. And you need a robot to do that. Without a robot, you can't get a functional alignment. And again, coming to balance, the number of methods to get the balance right by measure dissection or gap balancing methods, which are very traditional techniques. And then there's a dynamic balancing. There are a lot of sensors like Veresense. You can put a sensor between the knee and that will give force plate measurement. How much is the force, how much is the ligament tension on the medial lateral side. E-Libra is from Biometric, again does the same thing. Navigation does the same thing. And all these balancing are leading to better functional joint scores, with the sensors. What's new in that? So combined robotic precision cut with a dynamic balancing. This is a new concept. Most of the robotic systems in India don't have it. There's one system called Omnibot, which is not yet in India. And it's, I think, to my knowledge, only robotic balancer. It's a balance bot, in the market, and which guides the bone cuts. And the result is that you get alignment and balance, which is within 1 millimeter before you do the bone cut. And you know exactly how the balance will be post-op. And, this is going to be the future of robotics. And I'm working with the company quite a lot and how to integrate with other new technologies which has come up. Even today I had a meeting with a person from Miami and then London trying to sort this out as well. So I've been using robotics for 3 years in Bangalore, and it sort of gives 1 millimeter accuracy. There is a less soft tissue dissection and no release of the medial structures, and that leads to less pain postoperatively. Even the blood loss is very, very less compared to my traditional knee replacement. I've stopped blood transfusing in robotic surgeries, and all of them typically go 1 day before to home compared to traditional knee replacement surgery. So there is a lot of cost benefit to the hospital also. So, this is my first robotic knee replacement. Dr. Kaper is the founder of this particular technology. And you see on the bottom, it's marked in the green. The soft tissue balance of this particular knee from 0 degrees to almost 120, 130 degrees range of movement is like 1 millimeter up and down. That means it's perfectly balanced knee. So for the first time since the advent of robotics, we are getting objective evidence that our knee is really balanced. Earlier, we used to feel, oh, this is balanced. Somebody would say it's not balanced. Third person would say it's balanced. But now we've got objective evidence like this, where you can show that the knee is balanced throughout the full range of movements. So I'm sure Dr. Kapoor will be proud of that kind of a graft really in the first surgery. This is a post-op X-ray. This is the same lady in recovery. After she went to recovery, she is able to, basically straight leg rise, and she's able to, even bend the knee up to 70 degrees immediate post-op. Many of my colleagues in Mumbai call it as a dancing knee replacement, but we don't go into that kind of a thing. So, but she's quite happy. So I don't know if this video is going to play explain. So yeah, so basically she's able to straight leg rise. That shows that the extensor repair is good. And then good block from the anesthetist. And again she's able to bend the knee up to 70 degrees immediately. So coming to the next. Yeah, this is, I met Prof. Gregory, last year. He's an incredible guy, and he has launched what is called as a, the mixed reality robotics based, what we have termed, we basically use a Google Glass, and that really gives you a three-dimensional anatomy of the patient. And then on voice command, the whole robotic system works. And basically, what happens is, this we are called as an Iron Man kind of robotics. I'm sorry, I just went back. Let's see if I can go back one slide back. Very difficult one on the presentation mode to sort of go back. Anyway, we called it as a Iron Man robotics. So briefly, a few slides about the hip, hip and hip robotics. This is the hottest topic in orthopedics. If you go to any meeting worldwide, everybody's talking about this. They're talking about the relationship of our spine with the pelvis and the hip. So it has got a very complex relationship. So basically, what's happening is this hip replacement on the left-hand side was done in UK, not in India. If you look at it, it's almost a perfectly done total hip replacement. Okay, I think it's started playing now. So sorry, apologies. Just try to go off screen and come back again. Yeah, this will be called Iron Man robotics. So yeah, sorry, we missed one slide. Yeah, so to conclude, I would say that the robotics is here to stay in 2024, and we also probably need to think beyond robotics now with the advent of augmented reality and mixed reality systems. There are a number of advantages like enhanced accuracy to 1 millimeter, which is not possible with human eye, reduced bleeding and no transfusion requirements. Minimally invasive surgery is possible as less soft tissue is dissected, leading to less pain. And functional alignments mean the soft tissue is respected like Prof. Insall wanted us to do 50 years ago, and a patient-specific knee is now possible. Faster rehabilitation, going home one day earlier, that leads to cost saving for the hospital, better function, and the forgotten knee, as I mentioned, is a holy grail, because after knee replacement surgery, patients remember that they have an artificial joint. But with the hip replacement, they don't feel like that. So, we have to go to the forgotten knee, which is the holy grail of knee replacement surgery. And the soft tissue algorithm is the most important thing. With the AI coming in, that's going to come, and reduce cost due to reduce the revision burden, because a well-done knee will last 15-20 years. Then you don't have to revise like early failures, what I mentioned, within 2 years. Disadvantage at present are cost, because some of them are like 10-15 crores, and bulkiness, some of the robots are like 300 kgs. I think Iron Man robotics and NextAR is the solution, because you can carry it in a suitcase. So yeah, so briefly, a couple of slides on the hip. So this was what I was talking about, a perfectly done THR, total hip replacement on the left side. This was UK slide. It dislocates, because this patient has a stiff spine. And, the role of the spine and the hip is a very, very complex thing, which we are beginning to unravel in the last 2 years in orthopedics. Prof. Ed Davis is a professor of robotics, Corey Robotics in Birmingham. He was my consultant when I used to work in Royal Orthopedic. And I asked him, how do we demystify this? And he said, Sri, I still don't know what are the things because so many things are involved really. So I think, when dealing with hip, one has to be a little careful. So, this is another total hip again done in UK. This is not an Indian slide. And this looks well done kind of thing. But on the opposite side, on the right side, which is where it is not done, the neck shaft angle of the femur is it's in varus. So the patient is used all uncemented system is very popular in India. That basically forces the leg to get lengthened. So this patient successfully sued the surgeon in the UK because she had a leg length discrepancy following hip replacement, which she was not happy about. And because the varus neck was missed, so it's a popular stem. So it's a quick and easy to put these kind of stems. They're more expensive also. But I think, we should be very, very careful but to avoid all kinds of litigation because CPA 2019 is a reality for us. And, MLAG, Medical Legal Action Society, went into SC trying to get out of that. But sadly, we are still governed by the Consumer Protection Act, which is a sad thing. Again, this case happened in Bangalore recently. Just illustrates how if you fail to prepare, you prepare to fail during surgery. This was a difficult hip. It was a dysplastic hip in stage Pro 4. And, probably they went in. I think the issue what happened was maybe poor planning is the basis of that. But the length of the stem was too high and they had difficulty in reducing the hip once the operation was done. So then they managed to reduce hip and they were very happy that at least it's done, difficult surgery is finished. On the way to X-ray department, this hip dislocated because very tight. And then again, this X-ray showed like this, they can't leave it. So they brought the patient back, they reduced the hip. During reduction, because of the pull, the patient sustained a foot drop, which is a disaster. It takes 2 years for it to recover. And then again, it was not reduced. Again, further reduction led to the whole cup there. You can see the acetabular cup that completely spun out. All the screws came out as well because the patient sustained a acetabular fracture. And the uncemented stem that you see in the femur, it is well stuck. It's almost difficult to remove it unless you do osteotomy, break the femur and remove. So this was basically completely stuck. And then, 4 or 5 weeks later, a senior surgeon had to come and revise. So the whole thing is that get it right first time, drift, that's very important. Because my legal team always tell me, Shrikant, cost of litigation per case in Bangalore is, is 5 crores. So we hardly get paid 50,000 for these kinds of surgeries. Why honestly get into trouble, trying to earn 50K, we should not lose 5 crores, we have to be careful. So CPA is a reality. So there's a number of solutions for these kinds of difficult hip. One of the thing is called OPS, which is the optimal positioning of the cup. And robotics is an option. It's able to help us, and custom hips are also an option to get a proper alignment so that the hip do not dislocate following surgery. So my take-home message is GRIFT. Just get it right first time is a very, very important concept. And this mixed reality and robotics are an important and evolving concept in joint replacement surgery. The insurers, the patients, and the legal fraternity will demand this more from us in the future because we are becoming a kind of a risk-averse society. So training is a must to perform these complex work to acceptable standards. Some of them have a learning curve and better to leave it to the experience. And sometimes if you don't have any gadgets, there are very many things you can do like directional reaming. We have to position the patient properly, use the reamer at 40-45 degrees. That 40-20 kind of rule is there. Those things have to be followed to get things spot on. But if you get a stiff patient with stiff spine or a hypermobile female, these are danger marks. Okay, what I would recommend you if you're junior, best thing is to refer to your closest orthopedic surgeon, refer it because these are difficult challenges. You don't want to burn your hands with these kinds of things. Okay. And, as they say, live in a safe zone. What is the zone where the hip is safe? That's it's no longer valid now. So we are moved into functional hip axis range, which has to be followed. And dual mobility is a bailout. There are some dual mobility components where if there is some difficulty or high profile patients, you can put it and sort of get away. So my advice to younger surgeons is please don't perform surgeries watching, YouTube or Umidi. If in doubt, ask help. There's no shame in that. CPA 29 is really hostile to the Indian doctors. When things go wrong, we'll not only get roasted, also jousted, and also attacked by relatives. It's a very sad phenomenon in India. And there's used to be a popular saying in UK, when in doubt, refer to appropriate trained specialists. or opt for combined work. There's no shame, ask your seniors. Most of them are, colleagues who are going to help you. They can travel and come and help you. It's not an issue at all. Okay. And, as Dr. Pannar Academy clearly says, we have to evolve as human beings from competition to collaboration. I think this is the absolute need of the time. And this is how we can grow together stronger, really. Okay, these are the references for the talk. I really thank you for the patient listening. These are my details. If anybody wants to get in touch, they can take a snapshot. My center has just joined hands with the #1 orthoplastic team in India. They are not only in India, but the whole world. And SSOC always stand for quality. So I welcome any investor partners to join us. As a group, we want to create 50 hospitals in India. We are at 25. So, it's a great opportunity really. So anybody willing to invest 50 lakhs and above and be part of the setup, you are most welcome to contact me. We can take it further. Okay. Thank you very much. Pranav sir, thank you so much for your time. Thanks for this opportunity. Amit sir, thank you.